Thank you very much, Mr. Cavallo. If we could have Hugh Green and Bill Rupp and Jim Burkhart and Dan Wilson please come for the panel discussion and a presentation by Dr. Wilson. This is a panel of individuals who are very knowledgeable about our community and, of course, the healthcare industry. Mr. Green is the CEO, President of the Baptist Health System. Dr. Rupp is the CEO of Mayo Jacksonville. Mr. Burkhart's the President of Shands Jacksonville. And Dr. Wilson is the Vice President of Health Affairs and Dean, University of Florida, Shands Jacksonville. I think we are happy to have questions from the audience, but perhaps some comments from a few individuals first. Mr. Green, would you like to comment?
I'm going to do what you should never do, but I have an appointment in the governor's office with your friend, our chief of staff over there now, Adam Hollingsworth, in my role as chair of the Florida Hospital Association. That is at 1 o'clock. So I'm going to, I think it's very important to be here, and then I'm really, if you see me slip out, I'm not mad. But the reason I'm going over there is the exact reason why we're here. And it's the kind of issues from a Florida hospital perspective that Tony has talked about this morning. The thing that I really want to say to this group, if nothing else, the situation facing our safety net hospital, and to some degree, our children's hospital at Wolfson, and the reason I say to some degree, Wolfson's contained within a larger system, is a serious crisis in this community. If you don't hear anything else I say, this is a serious situation facing those people who seek care either because they are covered by Medicaid, which is so underfunded, or they are charity patients in the state. Now, that's been created by the serious number of cuts, again, due not to any ill intent, but the overall budget crisis, and quite frankly, due to the fact that, Jim, it's been how many years since there's been any increase from city? 10 years, the level of fundings of support from Duval County has not been increased. So that combination of situations has created a crisis, in my opinion. And here's the deal. If you believe that the state government's going to increase Medicaid funding significantly over the next 5 years, you probably can stop paying attention. If you believe that we're going to, in this state, expand Medicaid eligibility in accord with the Affordable Care Act, and that the state legislature is going to essentially override the governor's statement that we're not going to embrace Medicaid expansion, and there aren't going to be any additional cuts, then that helps everybody, because it means many of his self-insured patients and all of our self-insured patients are now covered. But quite frankly, I wouldn't wager 1 penny on either one of those options occurring. So if you've got a problem now, if you look forward to the future, there are 2 other occurrences to which Tony did not allude going forward that bring even additional uncertainty and murkiness to the situation. The first is we're in the process of 2 major transitions in the state Medicaid program, both occurring sort of simultaneously. One is we're moving the payment methodology for Medicaid from a per-day methodology to a DRG methodology. Quite frankly, the Florida Hospital Association has supported that change. Most states have taken, 2 to 4 years to do that transition. The legislature said we want to do it in less than a year. They've hired a consultant. The recommendation is supposed to be completed by December 31st. Now, in and of itself, that change in the methodology isn't necessarily negative for Jim and Shands or for anyone, but quite frankly, the rapidity with which we're going to implement that change, Tony had made the statement, we're suddenly painting with a whole new can of paint. And what happens sometimes in those situations, unintended consequences occur, and we're worried about that. So that's one transition. The other transition is the legislature has approved essentially a transition of Medicaid to managed care. Many of you have read that the managed care transition pilot program in Duval and Broward counties didn't go all that well. That's an understatement. Now we're going statewide. I refer to it, we're really outsourcing Medicaid to private managed care. And this is not in any way meant to be a slam. And quite frankly, I'm not sure that's necessarily an irrational move, except all of a sudden, again, a huge transition, a huge change, huge uncertainty. And if not adequately funded, and there's a lot of add-ons to how safety net hospitals are paid in the current environment with the low income pool dollars, et cetera, there's a real risk that things could get worse. So you've got potential new cuts coming forward, we don't know, in the state legislature. You've got transition in payment methodology, you've got transition in to managed care. This sets you up for a confluence of circumstances that make the already existing problem much worse. And so in my position, primarily as chair of the Florida Hospital Association, I wanted to just add my impetus to the fact that we cannot ignore this situation as it affects Shands-Jacksonville in our community.
Thank you very much. You couldn't be clearer. Jim or Bill?
Yes, I appreciate the opportunity to speak for just a moment, and I don't have any slides to show. I just want to cover a few things. I think it was said by Dr. Coble that we are not really unlike the other not-for-profit hospitals in the community in that we have the same responsibility as other providers for the uninsured and the underinsured. However, geography plays a large part with some of the capture of that particular population. So caring for this community is a community-wide problem. It's something that we all face. The issue is for how we better fund and provide the necessary care for those that are unable to provide the cost that used to be shifted, and it was hidden, to those with insurance. And as those payments have gone down, the shifting can no longer occur. Now, a good example for us, and this was mentioned by Hugh just a second ago, is the city contract. It really is, in essence, for us, a capitated plan. We get $23.7 million. Sounds like a lot of money, right? It covers roughly 10,000 covered lives. Okay, not 10,000 people in there at any given time, but 10,000 people go through that system in any given year. That's $2,300 plus a year for care for that population. I can tell you that that's a pretty sick population to begin with. We have a gap in the hospital side of $40 million a year in cost for that program, for that coverage group. The practice plan has about a $9 million gap, our colleagues who take care of those patients. Now, to be fair to the city, if they gave us nothing, those patients would probably still come. Okay? And it was mentioned by Tony that we do take those dollars, which are general revenue dollars from a governmental source, the city, and we send those and get a federal match, and it brings down some dollars that benefit us as well as the other hospitals in the Safety Net Alliance and low-income pool receiving hospitals. Because we do not have a tax base, unlike Miami-Dade or Sarasota or Broward's, there is no other tax base. The only intergovernmental transfers in Jacksonville is the city contract. So now I've messed up here. So I really want to shift my attention, though, to talk about what are we trying to do to address these issues. Well, obviously, we're doing things like controlling supply costs, managing staffing based upon volumes, taking care of patients at the lowest level possible. We've opened up lots of clinics in the community. We have after-hours clinics. We have free walk-in clinics in some of our sites in locations in communities that people can come in without an appointment, and we will take care of them. We've had to reduce our support to our colleagues in the College of Medicine by $5 million this next year, so that gives them a $5 million problem that affects education, training, and services. We've held back on significant capital expenditures, and in the short term, that works okay, but in the long term, that's not a good long-term plan. When I arrived at Shands in 2001, and the hospital was technically bankrupt at that point in time, they were spending about $400,000 on emergency capital and nothing on technology in the plant. Over the first 5 years of the recovery, we spent $300 million on capital, okay, and had positive bottom lines. The problem has been these huge reductions, and as Tony showed the $30 million, the cumulative effect for us has been $91 million on the Medicaid cuts. As if the volume were exactly the same as it were back in 2008 till now, today we're receiving $91 million less for that care than we received before. We have obtained medical home certification for 26 of our sites, and that was mentioned in one of the slides. And then we just opened this past week Total Care Clinic, and that is for the city contract. So we're going to have a single site location so that we can better manage the care for the city contract patients to include their pharmacy needs, their ancillary needs, their primary care needs, and their specialty care needs. So what kind of results have we shown? Well, UHC, which we belong to, which is University Health Consortium and has a large number of hospitals such as ourselves in the database, we are ranked number 1 in the lowest supply cost in the country. We are ranked number 4 lowest cost in cost per adjusted discharge in the country. We reduced our ED visits over a period of years from, when I arrived here, 125,000 visits a year on the campus, main campus, to 70-something thousand. And most of those patients are now being seen in these after-hours clinics and clinics in the community. We have implemented a 340B program that the government's allowed us to implement that has provided free medications to those that cannot afford their own prescriptions, and then we get reimbursed the prescription, not the money, but we get reimbursed. They refill the prescriptions to us for free. We have done outreach, education, and community health screening programs just like all the other hospitals in town have done. And we've improved patient outcomes and results. Our expected mortality rate, we are now in the top 15% lowest expected mortality rate in our database. So with all this said, the community must find ways to increase the funding if many of these needed services are to remain viable and part of the solution for access to care for all of its citizens. So thank you for letting me speak.
Thank you, Jim. Bill and Dan, which are you going first?
Let me put a very personal spin on this for each and every one of us and just talk about big picture for a minute. Most of the people in this room have decent health care coverage. And we could easily say we're talking about those poor people that are uninsured or those who are on Medicaid. But let me tell you how the system works right now, today. Medicaid pays 39% of cost. I actually think that's a generous overestimate, but let's assume it's real. Medicare is paying below cost. Now, a recent study suggests that in healthcare there's 30% waste, and I actually agree with that. So let's say we get that waste out. Insurance companies are rapidly moving. The way it's worked up to now is that we all make money by charging the insurance carriers more. It's cost shifting, absolutely. The insurance companies are saying, not anymore. They're saying, we're going to pay you what Medicare pays you. And we're going to see that happen across the country dramatically over the next couple of years. So now there is no more cushion. Let's say we take out all of the waste and learn to live at Medicare rates. And we're still getting 39% of cost from 22% of the Florida population. What happens to coverage and care for all of us? Just think about that. I mean, it's pretty dire when you think about the possibilities through this. So this isn't about the Medicaid population. It isn't about those poor people without insurance. This is about each and every one of us in this room and how we're going to tackle this problem going forward.
Dr. Coble, I want to just take a moment of personal privilege. In case you did not hear the announcement today, Dr. Bill Rupp has been named the incoming chair of the Jacksonville Regional Chamber of Commerce, and I want to take a moment to congratulate you, Bill, and also to just commend Dr. Rupp for his incredible community engagement in his role as the Mayo CEO. And so, congratulations, Bill.
Thank you. I'd also point out that Hugh had a role in that nomination, so I may come back and since he's the past chair.
That's why we're known as a collaborative community.